And you're live.
Good afternoon, and welcome to this year's BC Schizophrenia Society Annual General Meeting Educational session, Schizophrenia in the Time of COVID-19. My name is Jeff Bagshaw. I'm a member of the BCSS Foundation, and I'll be your MC for the day. When we started this year, we couldn't believe things are the way they are with COVID-19, and we've just been impacted in so many different ways, some of which we may not even be aware of yet. Today, I have the very great pleasure of introducing Dr. Diane McIntosh and Dr. Randall White, two members of the BCSS Medical Advisory Committee, who will speak on how the COVID-19 pandemic has affected families and families affected by schizophrenia. Dr. McIntosh and Dr. White will both speak for about half an hour. At the end of each talk, we'll have a few minutes for questions. So if you have questions, type it in the Q&A chat online there, and we will ask them their questions. If you have any difficulty, just hit the support question, and then they'll help you out. I'd like to thank again the sponsorship, Otsuka Lundbeck Alliance, for making this possible and allowing this to proceed with no donor dollars used at all. So I'll introduce Dr. McIntosh first. Dr. McIntosh is a clinical assistant professor at the University of British Columbia and also has a community psychiatry practice. She is extensively involved in providing continuing medical education programs to colleagues nationally and internationally with a focus on rational psychopharmacology, neurobiology of mood and anxiety disorders, as well as ADHD. Dr. McIntosh recently accepted the position of Chief Neuroscience Officer at TELUS and is responsible for optimizing all their mental health related products, services, and innovations. Since March, Dr. McIntosh has also been regularly offering tips and strategies, helping people manage with COVID-19 pandemic. Dr. McIntosh.
Screen. Let me see how that works. Share screen. Here we go. I'm going to share myself, I guess. Share. And then I'm going to go like this and like this. And Jeff, please let me know if I'm not where I think I am, which is in front of you with the big screen. So lovely to be here. Sorry, it was a little bit of well, this has been an annus horribilis for many of us. We had the pandemic, and I know that it's been some great challenges to overcome through this year, and particularly for individuals who are struggling with a mental illness, who already are somewhat vulnerable, and then on top of that, some of the big challenges that we're all facing. So when I was asked by Jean to do this talk, I wanted it to be a little more general, just talking about how we as Canadians, and especially those who are struggling with mental health, may be impacted, and some very simple tools that we can think about to help us to go through this time, perhaps with more wellness and a sense of calm and control. So I'm just going to talk a little bit about the health landscape, and while I would have loved to have been able to say pre and post-COVID, we are still mid-COVID and unfortunately on something of an upswing. Talking a little bit about the impact of mental health on people who are employed. And then actually, we're not going to talk about working with ADHD. Unfortunately, I forgot to take that one out. So let's talk a little bit about mental health care in the pre-COVID period in Canada. So most of you are aware that mental illness affects all of us. About 1 in 5 Canadians at some time will personally have a mental illness. And really what that means is that every single Canadian either has a mental illness themselves or loves someone who is living with a mental illness, working closely with someone who has a mental illness. So the reality is this affects every one of us, and we all need to pay attention and really try to battle some of the challenges that people who are currently living with a mental illness are struggling with. Now, I don't need to tell anyone who's listening that we have a real challenge with accessing psychiatry. And I do a lot of education. So the 2 surveys that I did are from 2 of the programs that I have. One is Psyched Up CME, which is, I just did one yesterday, all about neurobiology, but mostly it's focused on psychopharmacology. And I also have a website called Psyched Up that all started from helping people to use antipsychotics appropriately and switch between them. So I did a survey of about 1,500 people, a little under that, to ask family doctors, how confident are you in managing mental illness in your practice, and what's it like to try to access psychiatrists? So I'm not going to give you all the data, but I'll let you know that not surprisingly, 87% said they do not have adequate access to psychiatrists, which is negatively impacting their patient care, that they don't have the guidance that they need. 56% said they don't have adequate access, meaning it takes way too long, and 75% said the wait is somewhere between 6 and 24 months. Now, those surveys are from individuals across Canada in all kinds of different areas, from small towns to big cities. But we do have some statistics from a couple of big cities. One is in Vancouver, and many of you may remember this. It was a few years ago in 2011, where a group of individuals attempted to call every community psychiatrist in Vancouver, and they got in touch with 230, and only 6 agreed to see a patient within the next 2 months. And the comments in the paper, if you get a chance to read it, were that even then there were significant hurdles to get past to get in the door for the 6 that said that they would accept patients. I would say that stats in Toronto are maybe even a little worse. 50% of psychiatrists working full-time in Toronto see fewer than 100 patients a year, and 10% only see 40 patients a year. So those would be probably your Freudian analysts that have a very small number that they see every day. But our dollars are going to support these psychiatrists to see a very, very small number of individuals. The sobering statistic of 40% of patients who attempt suicide saw a psychiatrist within 6 months of their ER visit, and that means that 60% did not see a psychiatrist within 6 months of going to the ER with an attempted suicide. 50% of Canadian psychiatrists are near retirement age, and the backfill is very poor. So we had a problem in psychiatry, which you all know. We also have a problem in the Canadian economy with the fact that we don't have adequate care for our patients. So 500,000 Canadians are unable to work each week due to their mental health. 30 to 40% of all short-term disability claims are related to mental health, and 30% of long-term disability. This is costing $51 billion a year, and the expectation is that by 2041, it will be $2.5 trillion. That is a cost to the Canadian economy due to mental illness. The fact that people are not able to fully work, that maybe they're absent fully, and also presenteeism. You're there, but your brain is not. You're not working up to your optimal level, which is actually more costly, believe it or not, than absenteeism on world economies. What was also really interesting, this comes from the Morneau-Chappelle data that was earlier this year, actually. 60% of employees say they would actually take less money, they would accept a job that paid them less if their prospective employer offered better wellness benefits. 77% of workers said they would consider changing their job to an employer who offers better support for mental health and well-being. And that's one of the reasons that I'm in the job that I'm in right now, is trying to improve mental health care within this organization, also for all our customers. But when I accepted the job in January, I told Darren I would only accept the job if it meant that we were going to work to improve the mental health care of all Canadians, which is 100% endorsed within this organization. So I just want to take a moment to reflect on the definition of mental health, and I think this is a very good one. It's from the World Health Organization. I believe it was 2005, and the WHO defined mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his and her community. So I just think that's very important to point out that work productively is right in there in the definition of mental health. Now, economists, and I've read a number of different papers about this because I've given a number of talks on this topic. Really, when they're talking about mental health, they actually tend to focus on things that most people think about, like happiness and well-being scores, satisfaction with life, positive emotions, the perception of living in a meaningful way or in a productive way, giving back. The medical field has tended to focus on, you don't have symptoms. You're mentally healthy if you don't have symptoms. And of course, we use the DSM. But we know that the two are linked, right? That if you don't have good mental health, then you don't have positive emotions, you don't feel productive, you don't feel that you have meaning in your life and that what you're doing is meaningful. So I feel that the field of psychiatry really is changing, but the frustration for me is all of the talks I give where I'm asked to talk about making the patient, the individual I'm treating, the center of all care decisions. And I'm thinking, well, shouldn't we have figured this out a long time ago? I'm kind of tired of talking about this. This should be the way that we do things. Now, uh, there is absolutely no doubt that the economy and health, mental and physical health, is inextricably linked. So we know individuals that are of low income are up to 3 times more likely to suffer from a mental illness than a wealthy person. Job loss and income decline often precedes mental illness. And we have, unfortunately, data associating recession, economic turmoil within a country, and worsening mental health outcomes, more mental illness, greater substance abuse, and higher rates of suicide. And I just want to point out that the CDC, the Center for Disease Control, and we've all heard this a lot over the last 6 months or 8 months, they came out with suicide data in the last year showing that there was a massive increase in completed suicides amongst youth aged 10 to 24, that over the last 10 years, that has increased 56%. That is unheard of. And there's lots of different reasons, but they don't know for sure why. They have more guns in the US, certainly, but we have a lot of addiction issues and a fentanyl crisis, which they have an opioid crisis down there as well. But there's something else going on, and they were in a rich economy. So my concern is what will happen now? And our data on suicide is also very troubling. So the point of talking about our economy and the impact of work is that work is very good for you. That most individuals who have a mental illness, as most of you will know, even if it's a very severe mental illness, wish to engage in meaningful work. So despite the fact that some people in our society don't seem to understand the fact that people who are mentally ill aren't lazy and don't wish to engage in work, the reality is that most people, no matter how ill they are, wish to get back to work, and want to be gainfully employed and contribute to their society. And to the point of the WHO definition, this is the essence of mental health, or one of the critical factors in mental health. Paid employment, of course, offers financial security. It gives you a structure every day, a sense of worth, and regular supportive social engagement, which is quite powerful. And of course, missing right now for so many people who are working at home. Many studies have found work is associated with better mental well-being, lower prevalence of depression, and lower prevalence or incidence of suicide. Now, there is a value to paid employment, but many of my patients are not able to be gainfully employed, partly because they will lose their benefits if they are. So we are in a situation now where so many people who wish to be gainfully employed do not feel able to do so because of the loss of benefits that they will experience. There are some people that are able to work to a certain extent, but there is a value to volunteerism as well. So I know that I'm focused on the slide and paid employment, but I do believe that there's a huge value to volunteerism as well. Now, we are at a really difficult time right now with the COVID crisis. And the first time when I created this slide was actually in April or May, I believe. Well, it was talking about the fact that the stress that we were under as a community, as a society, really is the worst kind of stress. We know that stress is bad for our brain, especially if it is chronic and unpredictable. Acute stress can actually be quite valuable. It allows us to deal with situations quickly, to adapt, and also to learn. But chronic and unpredictable stress is actually a model that is used when we're studying different kinds of therapy, different kinds of treatment. It is a paradigm for depression. And that's really what we're living in right now. So we know that chronic unpredictable stress is associated with depression, with anxiety, with cognitive impairment, with all inflammatory illnesses. And for me, this includes obesity, diabetes, heart disease, Alzheimer's disease, structural and functional brain changes in our glial cells and neurons. And that's why it's very important, the impact on all inflammatory illnesses, Alzheimer's disease, because if your glial cells, which are those supportive brain cells, do not work properly, it increases our risk of dementia and many inflammatory illnesses. So what we're living in right now is what I call this COVID-19 mental health trifecta. We're all worried about our health or the health of the ones that we love. And so many people that I know are sort of jammed between, I got these kids at home and I can't take care of them because I'm supposed to be working full time. And I've also got an elderly parent in a senior's home or quite isolated. I'm worried about them. So they have health anxiety for themselves, for their kids, and for the people they love, and also for their whole community. Then we have the financial stress. So many people have lost their jobs. People have also maybe coming towards retirement and worried about their RSPs. And we're also worried about our own economy nationally and the international economy. And then we've got the impact of isolation. And we have very good data showing that loneliness and isolation has not just an impact on your mental health, but physical health. And I read a paper just last week talking about how the impact of loneliness and isolation has a similar impact on our overall health as smoking, inactivity, and obesity. So when we were at the height of this and we're moving back into another peak of COVID, we will have a resurgence of anxiety, of this financial stress, which everyone's worried about shutdown, as well as the fear of isolation. So we saw the impact early on with this COVID pandemic that Canadians were struggling with their mental health. There was a quadrupling of not just general anxiety, but high anxiety across Canada. There was a doubling of the level of depression across country. Of course, there were differing from place to place, but in general, it was about double of the usual rates of depression. There was about a 30% increase in the consumption of alcohol, as well as an increase in the amount of cannabis that was being used. And about close to 60% of recently unemployed Canadians, and this was from back in May, reported their mental health had a negative impact, was negatively impacted by their job loss, which isn't surprising. Now, my view of mental health is as a spectrum. Everything is a spectrum. Everything has shades of gray. And what I'm really focused on is wherever you are in the spectrum, I want to meet you where you are and then try to push back towards the left. I want to help and try to intervene before we get into the crisis mode, but there's a way to intervene at every place along this spectrum to help people feel healthy and be healthy physically and mentally. And I want to make that point here by showing ways that you could intervene even with a healthy individual. So if someone is otherwise doing well and we want to keep them well, we want to make sure that they keep exercising, that they're maybe improving their gut biome, which is a very, very exciting area of psychiatry, by having a healthy diet and choosing Mediterranean foods, even learning how to cook healthily and shop healthily, even if you don't have a whole lot of money. Mindfulness, meditation, all of these things are valuable for a healthy individual and help to prevent them from ending up in the stressed or functionally impaired. And certainly you don't want to end up in the crisis mode. So there are ways for us to intervene at every spot. And that's why I want to focus just at the end about how we can help people that may already be healthy or in any other part of this zone, how we can help to move them towards the left, towards the less functionally impaired, less stressed, and more healthy mode. And these are some very basic things to think about, but sometimes we don't think about them when we're feeling a little scrambled by everything that's going on. Most importantly, we all thrive on a schedule. And so what happened to many of us when COVID hit and everyone went home and they were working from home is that they spent most of the day in their pajamas and people were binge on Netflix, and they lost their normal wake and sleep patterns, which are really essential to well-being. So if you end up that you're able to go back to work, being able to have a regular schedule actually helps you to transition to work life. And anyone whose kid has gone back to school after the summer knows how hard it is if you don't have a schedule to get back to school. This includes all kinds of different things. What time you get up, what time you go to bed, making sure that if you're at home that you start and stop work at a regular time so it doesn't leak into the rest of your life, your family time, making sure you schedule time for fitness, for meals, and for fun. This is an essential time for adherence to treatment, especially if you're stuck at home. You don't have the normal outlets that you would usually have, and so mood, irritability, frustration, tolerance is really at the edge. If you take medication regularly, and it doesn't matter what kind of psychiatric medication it is, you're more likely to reduce side effects. And I often hear this with ADHD. People will say, well, I take a holiday on the weekend from my ADHD medications, which is not a good idea, because people, when they're driving, need their ADHD medications, when they're out with their friends, and they could be taking risks. And what happens is every time you stop and start, you're going to have more side effects. This is a place where LAIs are so valuable, and unfortunately, I think physicians are not the champions of long-acting injectable antipsychotics that they should be. We have some great ones, new ones, atypical ones that have less of the burden of some of the older ones, and they help with adherence. And I've kept more people out of the hospital because they've been on a long-acting injectable than any other drug. Avoiding avoidance, and that means that if you're worried about something, a lot of people, their first thing to do is to avoid it. And that's especially true with finances. I'm not opening those checks, those bills. I'm not going online to see where things are. And so if you have a loved one that you're worried about and you know they're avoidant, maybe helping them to go ahead and look at those things and make a plan, because that avoidance can make things certainly far worse if we let it go too long. The importance of trying to separate work and home life, trying to make sure that, a lot of people were working in their bed, in the same place where everyone else was, and you can't close the door at night. You go from your bed to your bed. So trying to make sure that you separate off what you're doing at home, at work-wise, from the rest of your home life. That's not possible for everyone. Going outside, there's actually data that hugging a tree, that being on the grass and moving around in green space actually does have an impact on health and well-being. Cannabis and alcohol, I'd love to talk to you all day about the impact of cannabis on psychosis, the risks associated with that, and particularly in the developing brain. But I also want to bring in the importance of alcohol, and because of the fact that there was data showing we were drinking much more than usual, nothing gets you to sleep quite like alcohol, and nothing messes with your sleep quite like alcohol. So if people are struggling with their sleep, trying to limit the amount of alcohol can make a big difference. And of course, when you're at home all the time, you don't have your usual outlets, it can be somewhat easier to go there. And trying to find positivity in this challenging time. I believe that gratitude is a gift I give myself every day and helps to keep me sane, but also recognizing that our anxiety is contagious to others, and especially to our children. So I'm going to leave you with this last little bit, which is controlling what we control. I have learned in my life, and it took way too long to learn, that the only human being on earth I can control is me. I can't control my husband, my kids, my patients, no one else, only me. And so this is why this time is so stressful, is because people feel completely out of control. We didn't have all the science. The science that we had at the beginning was mostly not right. And so we have these big black holes without information, and this is why conspiracy theories have ended up in there, and this has really heightened people's anxiety. So reminding people to get their information from reputable sites, to do the basic things that we know work to keep us safe: washing our hands, wearing gloves, keeping social distance, and trying to be around friends when we're outside. Trying to keep people, if we're inside with people, that we keep them at a distance. We know those things significantly, massively decrease the risk of COVID and will allow us to get on with our lives. And the last positive thing that I want to say here is, I am a glass half full kind of person. I'm always trying to see the positives here. And I think this is really an opportunity to talk to the people we love, teach young people particularly how to critically think, how to look at the news that they're absorbing, whether it's through Twitter or Instagram or whatever, and really critically appraise that, and help them to understand how you look to make sure that what the information you're reading is actually true and accurate. So I'm going to leave you with that, and I'm going to stop sharing here, and I would be happy to answer any questions that you have. And if not, then I do have another meeting, unfortunately, that I have to run to. I hope I'm still here. There I am. Hi, Jeff. So does anyone have any questions for me?
Thanks, Dr. McIntosh. That was fantastic. We'll just wait, see what questions come up. And if you have questions, type them in the Q&A box.
I would say, Jeff, I was a little bit all over the place with that, just wanting to give a little taster menu of a different thing. So certainly I wouldn't expect that people would have a whole lot of questions, but I'm happy to share my slides. Jean asked a question, how can Canada get more psychiatrists that work with people who have a severe mental illness? I'm actually working on a program right now. I am on the final steps of this journey to be able to set up a immediate access for family practitioners, for prescribers who can have immediate access to psychiatry, because that was really the reason that I wanted to connect with a company like TELUS, which has so much reach, is to create a program where we could give immediate access to psychiatric guidance. The program is called RAPIDS, and I'm in the final stages of being able to get this made. We got the whole process going, we got all the approvals, and so I'm hoping to have a what's called an MVP. I'm learning all about the business world here, a minimally viable product in the next couple of months. And I believe that this is really going to change the world of psychiatry, and it will include all psychiatric treatment, not just psychopharmacology, but that's really where family doctors need a lot of help, is with feeling confident and rational in their prescribing, but offering guidance both to the prescriber, but also to be able to share that guidance with patients as well. What is the current wait time for a psychiatrist in BC? I don't know. I know that I can't get anyone to see any patients that I try to refer. So I really struggle to find anyone who's actually taking patients. And I have had big challenges even trying to refer to the hospitals. But I maybe Randall, I don't know, Jeff, if you've had any access to any kind of those statistics, but I know it takes far too long. And when I cut back on my practice, I tried to refer patients, and I literally could find no one to take anyone.
Okay, I think we'll move on to our second presenter. Thank you so much, Dr. McIntosh, and have fun at your next meeting.
Thanks, Jeff. Bye.
Okay, I'll introduce Dr. Randall White. Dr. Randall White is a medical director of Vancouver Community Mental Health Services for Vancouver Coastal, and the clinical director of the British Columbia Psychosis Program at UBC Hospital. He's practiced psychiatry in Canada and the United States, and currently the president of the Western Canadian branch of the American Psychiatric Association. His clinical and research interest is in understanding severe psychotic disorders, and as a clinical professor of psychiatry, he's involved in many educational activities at UBC. He's also the co-chair of the very good annual Pacific Psychopharmacology Conference, and has educated the general public about mental illness at many events and in the media. Dr. White.
Thanks, Jeff. It's nice to be here with the BCCS once again, and I appreciate collaborating with you, all the families of people affected by this severe illness. So Jean got in touch and asked me to talk about the impacts of COVID-19 on people with schizophrenia. And, I thought it was an important topic, and so I started looking into the publications available, and honestly, I didn't find very much. This disease is new, obviously, and it's been affecting our populations for, less than a year. So, still, people are trying to publish things. I did see something pretty interesting recently, in which actually it was at the conference Jeff referred to, the psychopharmacology conference. We had an expert from New York come who has treated a lot of people with, a psychiatrist, a lot of people with COVID-19 in hospital who, have not people with schizophrenia, really. People who are acutely ill, very ill, in intensive care units because of the effects of COVID-19. Anyway, he described how there have been a lot of publications that are being retracted. In other words, they're published in a scientific journal, but it turns out that some of the information is wrong, or, I mean, rarely it can even be fraudulent. So it's a curious thing that there's some publication going on. Some of it turns out not to be that reliable. And I've, put together something here to share with you. And we can have a bit of discussion too, because some of your experiences may be as helpful as, what I can find just by looking through publications. I'm trying to share my presentation now. It's appearing a bit unstable for some reason. That's a problem. Is it flashing for everyone? Yeah. So I might have to stop sharing that and just talk about it. I can, though, send the file to Jean, and she can post it. And okay, hi. I think I am audible. I wasn't for a moment, but I am going to send the presentation to the producers, and then you'll be able to see it, I hope, when they get it on the screen, since my computer wasn't doing the job. I'm emailing it to Jean right now. Okay. So in the meantime, I'll just go ahead and tell you what the first slide was saying. The topics I'm going to cover, I can just explain or include the ability of people with schizophrenia or psychosis or severe mental illness to manage the isolation and the protective measures that are required to avoid contracting COVID-19. Then I'll talk about what we know, which is not much, about the relationship between coronaviruses and schizophrenia or psychosis. And then I'll talk about what complications from COVID-19 people with schizophrenia could be affected by, and which are the same as anyone, but in particular how they could have impacts on people with severe mental illness. And then at the end, I want to talk about the service impacts in our healthcare system of COVID-19 services I'm referring to in particular for people with mental illness. So let's go to the first topic. So if we, who most of us are not suffering acutely from a severe mental illness, and if we are having trouble with things like social isolation, distancing, adhering to mask protocols, then what about the people that I treat and the people in your lives who are affected to one degree of severity or another by schizophrenia? So I was able to find a couple of studies that looked at this, and as Dr. McIntosh already said, people with severe mental illness already have limited social networks and fewer social connections. So social distancing is only going to make that worse. And furthermore, some of the community services that they rely upon, like clubhouses or drop-in centers, have had to either discontinue service or adapt their service in a way to ensure social distancing, and that has typically reduced their capacity if they didn't close outright. Of course, especially last spring, in Vancouver, transit services were reduced, and I think they were in other communities in BC. And a lot of people with chronic mental illness, of course, don't have private transportation unless perhaps their family members are able to provide that. And so with less transit service, they had reduced mobility. So that could certainly have psychosocial effects on them. And then I think it's acknowledged and documented that people with something like schizophrenia at baseline have less access to technology, less likely to own a mobile phone, less likely to have high-speed internet. So, and given that our solutions to social isolation and things like even healthcare service access have relied upon the internet, that would exclude some people affected by schizophrenia. So the next frame you can move to talks about how people with schizophrenia might or might not be able to adhere to protective measures. Again, I found a little bit of published information. There was a study that surveyed some patients, and it found that they were less willing to take a vaccine. Less, and by the way, I should mention this wasn't specific to COVID-19. I think this was looking at possibly people in a place where there was another viral epidemic going on. Anyway, they were less able to remain in confinement and self-isolation. More likely just to continue their usual activities. They were willing to wash their hands. I don't know if the researchers were actually documenting hand washing per se, but at least in the survey, the respondents said they were willing to wash their hands more frequently, but mask adherence was not very good, and it seemed like some of the people tended to kind of diminish their own likelihood of contracting an infection, and then we know that patients with severe mental illness have less access to primary care. Now, if they're attached to a mental health team, Okay, so adherence to protective measures. I was talking about primary care. So it's well documented, as I was saying, that most patients have reduced access to primary care, and therefore they might have more difficulty, for instance, getting a test if they need it. Okay, moving on to the next slide. So I'm relying on Justin or someone to advance for me. Thank you. So I found that, I'm sorry if the sound quality is a problem. I'm not sure why, but this research I thought was pretty interesting. And there's not a lot out there, but this was a 2011 study from the US, which looked at 106 people who had psychosis and 196 who did not. And the researchers wanted to see if the people had antibodies in their blood indicating a previous infection from COVID, not from COVID, I'm sorry, from a coronavirus. You know, there are lots of different coronaviruses. And COVID-19 is just the one, the newest one that's causing a severe epidemic human illness. So they found that there were 4 coronavirus antibodies that seem to be more common in people with schizophrenia. So again, not COVID-19, but could this mean that coronaviruses, even COVID-19, predisposed to schizophrenia? It's an open question. I hope not, but we know that there has been a sort of viral hypothesis of schizophrenia. And for instance, if a woman has influenza when she's pregnant, there's a little bit of a higher risk that her child could develop schizophrenia. Okay, if we can move to the next frame. So I highlighted a few of the possible complications that might occur if someone with schizophrenia is treated for COVID-19, if they develop and are treated. So during the COVID-19 illness, which in most cases is mild, relatively mild, and doesn't require hospitalization, but is still pretty unpleasant, people develop things like insomnia, some anxiety, lower mood, and fatigue. And so we can imagine that someone with a chronic mental illness already has some of these things at baseline, so those could get worse. And there is a number, a proportion of people who have acute COVID-19 who go on to develop chronic symptoms, including things like fatigue and some mood changes. We have a lot more to learn about that. Now, then, of course, the lungs are the principal organ affected by COVID-19 in a severe form. And people with chronic mental illness have a high rate of tobacco use, like 70%, 50 to 70%. They use tobacco. And so they're at high risk for pulmonary disease already. So smokers do have a worse course if they develop COVID-19. Then there's the issue of pneumonia, and people with COVID-19 develop essentially a viral pneumonia, but they can also develop a bacterial pneumonia on top of that. People with antipsychotic treatment are also at somewhat higher risk for pneumonia, especially clozapine, possibly because antipsychotics affect swallowing. Then there's delirium. So this is the major neuropsychiatric problem in people with severe COVID-19 in hospital. 30% of these people in the intensive care unit, maybe more in some places, can develop delirium. Delirium is acute confusion in people who are medically ill. Delirium affects your ability to stay oriented to your environment. It affects your memory, and it affects your behavior. And it can also be associated with paranoia and hallucinations. So it's bad for anyone, and it's probably worse for people with schizophrenia. Then there are medication interactions. So people who are severely ill with COVID may receive some medications. They could have interactions with their antipsychotics. Steroids are being used more in severe COVID. They can cause their own neuropsychiatric effects, including paranoia or mood changes. COVID is also associated with a kind of, I think a small number of cases, but a kind of encephalitis. It also affects the meninges. Those are the tissues surrounding the brain. So in other words, meningitis, encephalitis, and then stroke. Stroke is well documented in COVID. COVID causes increased blood clotting. It also causes blood clots in the lungs. Okay, next slide. So I did want to mention a little bit about clozapine, because people with severe schizophrenia end up taking this in many cases because they don't get better with other treatments, and it does require regular blood tests. In most cases, after someone's been on it for a year, they can have a test once a month, but earlier in the treatment, they may require a test as frequently as once a week. So in patients who have had normal blood counts, and we're looking at the white blood count especially, if their blood counts have been normal, we've been able to, with the approval of Health Canada, reduce the exposure of people during a pandemic to the general public and having to go to a laboratory where there might be other people with various conditions, including COVID. So we've tried to take advantage of that when it's possible to reduce the blood testing burden. But the other thing I'll say about clozapine is, if somebody developed COVID infection, any acute infection, in fact, that can make the blood levels of clozapine go higher and even cause toxicity. In severe toxicity with clozapine, there can be oversedation, seizures, and it increases the risk for pneumonia. So I haven't actually seen this happen to any patients of mine, but it's a theoretical risk that we need to keep in mind. Okay, next frame. And then this is the last one I'll go through. Clinical service impact. So, I can talk about my experience with as a medical director, and just say that there were significant service impacts last spring. We might be facing that again this fall because of staffing changes, the need to create inpatient services just for people who are COVID positive, and also the need to reduce exposure risk for other people in hospital and hospital staff. So of course we're wearing PPE even on psychiatry wards where we usually don't do that. We're relying more on televisits. ECT, electroconvulsive therapy, also had some reduction in availability, although it's back to normal at the moment. And finally, reduced access to substance use services, including harm reduction. And of course, we're facing the other public health crisis, which is the overdose crisis. And of course, many people with schizophrenia schizophrenia have concurrent substance use disorders. Okay, I'll stop there so we can talk about some other things, or you can bring up your questions.
Thank you, Dr. White. That was fantastic, and we will get a better audio recording of that when we record it and put it on the web. So thank you very much for that. Does anyone have any questions? There's is it one question come up? Is it a predisposition, or is it that the very old ones may take less precautions?
Sorry, Jeff. I wasn't able to hear the first part of that.
Sure.
Although I think I can see it in the chat.
Yep, absolutely.
So predisposition. Okay. Sorry, is what a predisposition though?
I would assume that means to getting COVID.
Okay. So I don't think schizophrenia itself makes you more likely to get COVID. It's just that if people are not adhering to the public health regulations and maintaining social distance, which some people with psychosis seem to have trouble with, that would increase the risk of contracting it. I haven't seen any numbers that actually document that yet. So we're just kind of prepared for that. And we'll have studies eventually, I'm sure, that will tell us whether that's the case or not.
Yeah. Another question came through. What are the age groups in the complications study?
So those complications I went through, that they weren't necessarily from one study. Some of them have just been kind of described as anecdotal observations, but in general, the age group we're talking about are adults. Children are certainly not immune to COVID-19, but they tend to have a much milder case of it. And of course, people over the age of 50, and especially over the age of 70, have the worst complications from it. And those would be the ones I'd expect would be more likely to develop things like delirium and stroke. But there have definitely been cases of stroke in young adults and middle-aged people too.
Yeah. Another question came through, essentially echoing what we've been saying. How can we possibly provide increased services due to COVID when there's not even enough facilities as it is?
Well, I don't think I can answer that question really, but just acknowledge that it's a challenge that we're facing, and I'm a little part of a huge system, and we're thinking about this every day. How can we make sure that we're providing the essential services that our patients and families need, while dealing with these other requirements of a pandemic? And one approach has been to offer more services virtually, as well as sometimes to reduce the frequency of certain contacts in some cases, that kind of thing. But anyway, it's an ongoing challenge that our system is facing, and every health system in the world, honestly. I mean, whenever there's a peak in these COVID cases in a community, that health system is going to be strained. It's
yeah. Sticking with the health system, would there be more relief if more psychiatrists could be graduating at UBC and other universities?
Well, of course, psychiatrists are very valuable. So are other mental health care providers. but we graduate about I think 18 a year at UBC, and that has gone up over the past decade or so. We've got psychiatry residents in Prince George, in Victoria, Fraser Valley, Vancouver, and we could expand that hopefully to maybe the Okanagan one day. So sure, it would be nice to train more. We have to have the capacity at UBC to do that.
The question came up, just a clarification on the influenza factor and schizophrenia and pregnancy in women. Does the same theory apply to COVID-19 in pregnant women? Well,
that would be interesting research to do. Maybe someone's doing that now. It's, we have no idea, right? Because people don't develop schizophrenia until they're maybe 15, 16. And then some people, especially women, are more likely to develop it in their 20s. So we're not going to know the answer to that for more than a decade.
Yeah, no, for sure. Last question, and then we'll wrap it up. How do you see conspiracy theories playing into the paranoia of those with schizophrenia?
Well, I did see a little mention of that, and in some of the reading I did, but in my own observations, I have seen a little bit of that. I have had a patient or two who, said that they didn't believe it. They thought that it was being made up or whatever. So yes, people with schizophrenia, as we know, have delusions. They also sometimes just have unconventional ideas, even if they're not a bizarre delusion. And they are more prone to believe some strange things floating around out there on the internet and elsewhere.
Okay, well, thank you very much. And that's all the time we have for today. Again, thank you to Dr. McIntosh and Dr. White for helping us understand better how COVID-19 is impacting people and families living with schizophrenia. And again, as a reminder, this afternoon was generously sponsored by the Otsuka Lumbeck Alliance to allow us not to use any donor money whatsoever to put on this event. And a recording within a day or so will be available at www.bcss.org. Thank you so much for joining us today, and have a great afternoon.